Welcome to the NMI podcast, and we're in for a treat today. We're speaking with Dr. David Unwin, whose work I've admired for many years. He's quite the mover and shaker in the United Kingdom, shaking up clinical practice and policy at the same time, which we're going to dig into. Just by way of background, for those of you who are not familiar with his work, he's an award-winning GP known for pioneering a low carbohydrate approach, particularly in the United Kingdom, but I would arguably say that his work really is having a global impact. He's a Royal College of General Practitioners, RCGP, national champion for collaborative care and support planning in obesity and diabetes. He also won the NHS Innovator of the Year award in 2016 for his research into diet and lifestyle interventions. Has worked at Norwood Surgery in Southport since 1986 as a family doctor, and I think we'll see that his patient-centric clinical approach really permeates a lot of his work. And to date, he's helped, he may correct me on this number, he's helped 141 patients achieve drug-free type 2 diabetes remission. I'll just repeat that, drug-free type 2 diabetes remission, because they're big claims, but we're going to talk through that and understand what that means, how he's got to this, and broadly achieved a remission rate of 51% in his patient cohort. So welcome, Dr. Unwin. It's a real privilege to be speaking to you.
I'm excited as well. It's very kind of you to let me ramble on in front of people like this. I'm just wondering how I can best intrigue your audience, really.
Yeah, I think a good way to start is just to give us a bit of an overview on the work that you've been doing with diet in clinical practice. And, I know you've been involved with this for many years now and are sort of deep in this, but for a lot of general practitioners who are managing patients with diabetes or even, other healthcare providers and individuals that are involved in this, the use of diet to put people into remission, and I'll couple that with your approach, which includes de-prescribing medication, is, quite novel and runs against the grain a little bit. So I'm just wondering, how did you get here? Like as a family doc, how did you start using diet in practice?
How did I get here? I think it begins with being disappointed. So, I was a very enthusiastic young doctor, and I remember starting, you put up your brass plaque and think you're going to make a difference. I picked general practice because I knew that the continuity of care that is part of that is an opportunity to make a difference. And so as a young man, I thought, well, I'd rather be a larger fish in a small pond. So I picked a small pond and jumped in. It didn't work out very well because 25 years later, so I started in 1986 as a young man. And then 25 years later, I had to admit I was bitterly disappointed with what I'd achieved with my career because I didn't really feel I was making a difference. And when I examined that, it was to do with all the prescribing. I remember spending hours and hours just click, 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 which was the repeat prescribing on the computer. Just mindless clicking as I authorized all these prescriptions. And I started thinking, first of all, what difference is it making? Because to me, the patients didn't look well. And it was so depressing because I was, we'd start with one drug and then another and then another. And I felt I was sort of managing decay, a bit like a dentist, rather than a doctor. And what I was hoping to do was see improvements in health, real improvements in health. And I just wasn't. And really, these days, most GPs pack in, about 55. So I thought I was going to do something completely different to do with bird reserves. And I thought, well, I'll retire. I'm so lucky because I have a very, very clever wife, Dr. Jennifer Unwin, She's a clinical health psychologist, and she said, this is a bit miserable, David. Why don't we just try to do something that's fun, that mixes what I know about psychology with what you know about communicating with people and the health of your local population. And she just read a book, Beat the Diet Trap, by Dr. John Briffer, who many people have forgotten now, but he was a real pioneer. And she kept saying, David, you need to read this. You need to read this. When I read it, it was all about really metabolic health and diabetes. And I was really astonished, is the word, when I started to think about how is it that I had never considered the true causes of so many chronic diseases? How was it that I took this just sticking plaster approach and giving my patients medications, which certainly the guidelines suggested I do that? How had I fallen asleep at the wheel for 25 years with no thought about the true causes of many chronic diseases? And then when there was that against a really worrying epidemic of type 2 diabetes. So our practice had really, since I'd been there, I'd seen a 10-fold increase in the number of people with type 2 diabetes. And how can it be that I hadn't noticed a 10-fold increase and that really health was deteriorating in my watch, so that the local population were far sicker in 2012 than they had been in 1986 when I started. So I'd looked after the same population for this time, 10,000 patients approximately. I'm one of 9 doctors. But we've been absolutely hit by epidemic, well, several epidemics. One is type 2 diabetes. Another is central obesity and fatty liver. And they have ushered in some terrible consequences for my patients, because we know that central obesity is linked to 8 forms of cancer. And of course, the diabetes kills you through cardiovascular disease. So how could I not have noticed all this? And how could I not have thought that, it could not be genetic. It could not be genetic because you don't have a big change in a population in 25 years. That's a single generation. So it must be a change in the environment affecting a genetic predisposition. And surely we should be doing something about this, particularly as it affects younger people, which it really does. It really does. At university, I went to Liverpool University, and we were taught that type 2 diabetes in those days had a different name. It was called maturity onset diabetes because it was for old people like me. And now, in every clinic, I'm seeing people under the ages of 25. And really, how can we remain silent? We must do something. Anyway, so that's the preamble. And then we come to well, really, again, I hadn't thought about it, but the book suggested I look at the food supply. And a really simple approach is maybe avoid foods that put your blood sugar up. Would not be a terrible idea with diabetes. Maybe eat nutrient-dense food that doesn't put up your blood sugar. And we started doing this. I learned with the patient. So I'm a champion for collaborative work, and it's because I know that it's so much more powerful if you work with people rather than assuming I'm some sort of genius who you're going to do exactly as I say. So we set off with 18 patients who volunteered, and we met every Monday night, trialing a low carbohydrate diet. Just 18 patients. And a nurse, wonderful nurse, joined us, and we all worked for free because the partners really disagreed with what I was doing because they felt I should be, I don't know what, they felt I was wasting medical time on people who didn't deserve it, which sounds terrible, doesn't it now? And oh my goodness, we had some arguments. We had some humdingers because when you believe something, I was senior partner, and it was Jen who pointed out, well, there's always another way to skin that cat. So why don't we just do it for free? Do it for free. And I said to the partners, just indulge me. I'll work for free. I just use the waiting room. And if it doesn't work, promise to shut up. Anyway, the results were absolutely astonishing. I had never, ever in all my life of using drugs seen the percentage improvements in the metrics I was measuring. I was troubled, really. I was kind of excited and troubled mixed because the results, so liver function, people who'd struggled with abnormal liver function for years under my care, people I thought were probably drinking, well, they gave up sugar and starchy carbs, and the liver function would improve in weeks. People one lady I'd sent her to 3 separate specialists who told her off for drinking. Well, she was cured in weeks. And then on top of that, so other things, so liver function improved, blood pressure improved, obviously average blood sugars improved. I was seeing improvements across the board in terms of cardiovascular risk. And then I had a problem because at this point, I'd never done any social media. I'd never written anything, never thought of how to communicate with the broader public. And yet it became clear that I had a moral imperative that the world should know about this because people were improving and coming off drugs in large numbers. So I thought, right, so who are the leaders in diabetes? And I wrote to 20, it was about 20 professors to say, I'm so sorry to bother you. I'm Mr. Nobody from nowhere. But I'm getting these weird results and I don't know what to do about it. Out of the 20 professors, only one answered. That was Professor Roy Taylor from Newcastle University. I owe him such a lot because he said, what you are doing is important. These results are credible, but you must publish.
Mm-hmm.
And I had no idea how to do that. I remember to get the statistics done, there was a trainee accountant who knew how to use an Excel spreadsheet. And this 18-year-old came along and in moments had filled an Excel spreadsheet. And then Roy Taylor did the stats. And that was the very first paper. We've now done 25 peer-reviewed papers. And one of them, again, this is amazing, has been the most popular paper that BMJ Nutrition has ever published. And what this shows is that not just the medical world, but the broader academic world is very interested in the idea that diet makes a difference because that altmetric, the average altmetric for a paper is about 7. The altmetric, the popularity of this paper is 3,400. And it's been covered by the television, the New Scientist. It's gone absolutely mad. But it's a very simple idea. It's a fundamental idea that maybe what we eat makes a difference. And maybe what we eat can make more of a difference than the drugs we take. And that's slightly revolutionary. And certainly I wouldn't have believed it if you'd said that to me. I believed in my medication. And of course, drugs are very important. They save lives with antibiotics. And they can be really important. But, these chronic diseases, I'm beginning to see lifestyle and the way that our lifestyle no longer suits our bodies as part of so much suffering and chronic disease. And I'll just add a little bit more and then allow you to ask another question. But there was another very remarkable occurrence at this time. Was one of my patients said to me, "You do realize on social media, this is huge." Of course, I hadn't realized that because I didn't believe in social media or mobile phones. I was tutting about anything like that. Anyway, he said, "Oh, have a look on diabetes.co.uk." And to my amazement, there were 40,000 people on there helping each other to improve their diet and get their diabetes into drug-free remission. 40,000. I mean, I was quite amazed. But the tragedy of this was those people were being ridiculed for their efforts to improve diet by healthcare professionals like me. I saw this and it broke my heart because I thought these are people trying to learn, trying to do well, and they're not being supported. And this is clearly wrong when you have motivated people getting results. And it just so happened that at that time, diabetes.co.uk were designing a low-carb module, an online thing. But they didn't have any healthcare professionals. And so I volunteered because I was concerned, would it be safe? You know, you have to be very careful when you're dealing with large numbers of people because they might be on drugs, all sorts of things. Anyway, so Jen and I helped them. And that e-learning module, in the end, went to 460,000 people around the world. And it just shows the power of what is a grassroots revolution, where people are becoming very interested in the difference their diet makes. And I think I'd summarize this as human beings. I used to think of us rather like rats, as highly adaptable, and we can adapt to anything. It's not quite true. Because we spent so long as cavemen, we're actually adapted to the world of a caveman. And so we're adapted to a world that no longer exists. And what I'm trying to do is help my patients and the broader public understand what is their ideal fuel and their ideal way to live. And can we get as near to that as possible in our modern lives? Because I think there is a mismatch between what most people are eating and what would be their best fuel. And that the result, this mismatch results in not just physical ill health, but also mental problems. And I think I keep looking at people, and initially I thought, oh, diabetes, just don't eat stuff that puts your blood sugar up. But then they were telling me, oh, my mental health's loads better. You know, I don't think I need the antidepressants anymore. And my skin, I've stopped using the cream you gave me, Dr. Unwin, or my inhalers. You know, is it wrong? I stopped using my inhalers. And so gradually, as the years went by, I could see that this approach about the fundamental causes of ill health and the search for how we are adapted and what is our optimal diet just became so interesting, but so rewarding in terms of the patients I see in my clinic. So we've got the broader thing with the 460, and then there are other ways we might come to, like the teaspoons of sugar thing that's gone to millions and millions of people around the world. But in my own practice now, we've got 27% of our entire NHS diabetic register into drug-free remission. And a result of that, we've saved £370,000 on the diabetes drug budget for the practice. So, it's very kind of busy making. At least, at the very, very least, I think it shows what is potentially possible within the British Health Service in 10-minute appointments. And that's got to be a beacon of hope. And we see so little hope around us. We see so much that seems to be getting worse. That's why I can't give my practice up. I can't stop, because it's such oxygen seeing transformed patients. And I love deprescribing, saying, shall we have a crack at this next? We've got your blood pressure better, and getting people off their diabetes medication. We must say this is type 2 diabetes, of course. It's not type 1. But even the type 1s, we're reducing insulin. I'm going to stop now because it's time you asked a question.
Well, firstly, I think that's incredible. And, I'm sure I would share listeners' experience in basically just wanting to applaud the work that you're doing. It's a huge impact, to countless people's lives, and really doing something that is, and I don't use the word revolutionizing lightly, but revolutionizing healthcare. So, just a moment to acknowledge what you're doing. But, I think, beyond this sort of journey that you've been on, and the clinical work, the patient experience, that, that scaling through technology, I know some of the work you've done has also influenced policy as well. I believe from memory, you've had some influence on NICE guidelines for the management of diabetes. And I'm just wondering, has this been picked up and been influential in terms of policy change around diabetes management?
Yeah, there are some good things. I mean, my Royal College of General Practitioners were very helpful. In the beginning, again, it was this moral feeling that I need to tell people it's no, yes, I can help the patients at Norwood Avenue, but what about the effect of diabetes worldwide is terrible. If you have poorly controlled diabetes, you're losing a third of your life expectancy due to heart disease, but also cancer. And so I started thinking about how to communicate on social media. And then I was also thinking about how to be more effective within the profession. Because in the early days, well, I was actually shouted at for what I do. People stood up in medical meetings and said I should be ashamed because there'd be vitamin deficiencies and they'd come to harm. I was really shouted at. And that scared me, but also mystified me. It did me a favor, because I could see then the importance of evidence. Really, really important to audit what we do as clinicians and then publish. And so I started collecting data. And that led to better publications, but also, rather than just shouting louder than other people, it's far better just to say, well, you may have a point. I've actually audited my service and I know the average weight loss, blood pressure improvement, and in fact, all the changes in cardiovascular risk. And then you're taken more seriously.
Yeah.
It's very difficult sometimes under fire to, and the other thing is inexorable courtesy, because sometimes people are sincere and worried. So that this led to publishing papers. This led to then some media interest, because gradually, so I'm very active on Twitter. I've got 110,000 followers on Twitter. And then, of course, you've got media interest. You have influence on social media. And then the politicians start being a little more interested. So I think I have been granted time with 3 separate ministers of health, and been given time to talk to them about what I've achieved. On top of that, I'd say, to be fair, the whole world of nutrition and the difference it makes to health, the number of publications is rising and rising. And across the world, it's providing evidence, where we have evidence far more than my minor audits of service provision. But there's some whopping meta-analyses now. And this has combined all of this together, the press, the social media, just the simple idea that we should avoid putting our blood sugar up if we have diabetes. Isn't it amazing that I have to even say that? But the final part has been continuous glucose monitors, because for curious people prepared to buy them, many of my patients will, they learn a lot and fast about what's the problem. And the problem is often bread, breakfast cereals, chocolate bars, these things. And people start learning what their problem is. And all of this has combined, finally, to influence guidelines. So the big news is that it was January of 2025 that the NICE guidelines for adults with obesity have now include low carb as an option. I mean, that is amazing. And at the same time, rather kind of disappointing that it's taken that long to avoid junk foods. And, but anyway, it's there and we should, I'm grateful. The NICE guidelines, the revised NICE guidelines for diabetes are due out in July. And I'm optimistic that now, surely if you're told that low carb is an option to lose weight, if you have a weight problem, it's inconceivable they can't say, avoiding foods that put up your blood sugar is also fine in type 2 diabetes. We can't, it isn't in the bag yet, but I'm optimistic. So it's all of these things together. The grassroots revolution is so important because a great many doctors have learned from their patients. I learned not just from Dr. John Briffa's book, but from a single patient who put her diabetes into remission at the beginning, a thing I didn't know was possible. And the grassroots revolution, it's interesting how it goes. Starts with intelligent, motivated people, then primary care, because we're on the front line, and then now secondary care. And I noticed, so I helped found a charity, the Public Health Collaboration, some years ago, and we have a big international conference. There were a lot of consultants there this year from many different disciplines, psychiatrists, endocrinologists, orthopedic surgeons. So it seems to be going upwards through the hierarchy, but we must never forget the grassroots revolution, that because that's giving us some political clout. I must say help. By the broader media are fascinated by this. So, I mean, this week alone, I'm working on pieces I had 1,200 words in the Sun on the Sun on Sunday, on 2 days ago. I've got 1,700 words coming out in the Daily Mail any day now. And I've got the Telegraph doing 1,500 words. So the media are becoming curious about this odd thing. Partly the fat jab thing is worrying them, and probably so it should. Anyway, that's enough rambling. You need to get me back on course now.
That's a great way to paint the picture of the influence this has had at a macro level, and it's wonderful you ground that in where it's come from, which is a grassroots revolution. I think there's a salient message in there for all the clinicians out there. What I'd like to do is veer off into another area, which is the topic of ultra processed foods, and I know an area that you and your wife Jen are working on is this addiction to ultra processed foods. So, the way I look at it, and I don't know if you agree, but it feels like this ultra processed food environment is almost the antithesis of, or the direct opposite to what you're doing with patients. So I'm sure you've got a lot to say, and it'd be nice to just unpack this impact of ultra processed foods and explore whether or not they are, are indeed addictive.
Right. So in the beginning, I felt I wanted my patients to avoid kind of products vaguely. And it felt better to try and help them adopt a whole food approach to their various illnesses and problems. And as I've said already, the initial results was just so wonderful. But then, as the years went by, we had a recurring problem, which was people who knew how to keep themselves healthy would they'd go in reverse. And particularly after Christmas, I'm very busy every January because it seems that people will have a day or two off, like a little holiday, and then really struggle to get back on it. And some of those people could struggle for months. And some of those people struggled for months and had an amputation while they were struggling. So this really got my attention. I've learned, let's say, Jen has taught me to be curious about what I see. Just hold it there lightly, something you observe. You don't know why it is, but just hold it and be curious and look around. And so there was this phenomenon of clearly intelligent people starting to eat the very foods that I knew were damaging their health. And initially, I called it carb creep. And I'd say to people, you've gone a bit sugary. Are the carbs creeping back in? And they'd often say, yes, I went on an all-inclusive holiday or whatever, and I don't seem able to get back on it. Then I thought I'm trivializing something by calling it carb creep. That sounds like it's just a bit of naughtiness, mild, Christmas naughtiness. But actually, people die like this. I signed death certificates on this, and I've had amputations. So it's rather more serious than calling it carb creep. And of course, Jen is a consultant psychologist. And she suddenly realized this, I don't know, 7 or 8 years ago, that she was a carb addict and that her relationship with some foods was just the same as nicotine or alcohol. And I particularly remember one Christmas where she had a little bit of carb creep, but she didn't regain control of her ability to not have bread and other things till May. She struggled and struggled and struggled. It was Monday, next Monday, next Monday. But while she was struggling, she was getting heavier and heavier and making tray baits, supposedly for the children, and then scoffing the lot herself. And there was also secret eating going on too. I love her, and I watched this, and we kind of thought, this is addiction. This is addiction. And what is addiction? Addiction is intelligent people doing things they know can harm their health, like nicotine, like alcohol, things that and drugs. I mean, I'm really familiar with that in primary care. But what a shock that I knew teenagers when I started being curious. I had teenagers addicted to these energy drinks. Teenagers drinking so much of this, they had obesity, but they wouldn't eat protein because they were filling themselves with energy drinks. And so this idea of being addicted to ultra-processed food, I thought about it, and then every time you go and buy petrol, just look around you. Look at what's for sale on those shelves. Every one of them is addictive. You can go there and you can get your alcohol and your cigarettes and your chocolate bars and your crisps. They're all addictive. And it explains such a lot for me of why is it that so much of society is eating the foods we're not adapted to eat, despite knowing that it does us no good. And then Jen took it another step forwards. she said, well, if you think about this a bit like smoking, could you ever meet anybody that doesn't know that smoking causes cancer? No, everybody knows that. And yet people still smoke. So supplying information about addictive things isn't always enough. Because if supplying information would cure all my patients, I will have cured them when I told them, bread might be addictive. That
Yeah.
isn't enough. Why isn't it enough? Well, it's not enough because one of the main ideas of modern nutrition has been moderation. This idea that moderation is being reasonable. Well, there are many, many people who cannot moderate their junk food input, but that may include bread. So I am really so many people addicted to bread. And some of them, when I ask, could you be addicted to bread? They actually burst into tears because they've told nobody about this. And that's because we have this paradigm of, moderation. The idea is you should be moderate with this, that, and the other. And I started thinking about the concepts of moderation. What does it mean? It's absolutely meaningless. Are there a number of grams that is moderation, or is that? And against that is the treat mentality, which is I am entitled to have a treat every day, maybe a sugary treat. But there's a conflict there because it's a bit like the idea of freedom. Do you want the freedom to have sugary treats, or would you like the freedom from chronic illness? And that's a choice. You can't have both. So the whole food addiction thing, where if you can't have moderation, you have to try for abstinence. And some people find that very helpful. That Jen has to, first of all, identify what are your problem foods? What are the foods you're not sure you could live without? And they're probably the very ones that you should try and live without. And Jen has now refined all of this. She's done a 3-center study in the States, here, and Sweden,
Wow.
where she's looking at what are the outcomes at 1 year if you help people abstain. And of course, it's a happy story. And so I'm looking at diabetes remission. She's looking at remission of ultra-processed food addiction. And she's getting really great results on and published. And now, what we're doing in my practice is supporting people who are struggling rather than being critical of them. And we're not fat shaming people. We're understanding why they struggle to take our advice, and we're supporting them and helping them identify the foods that they need to abstain from. And I would imagine, Ben, in your clinical practice, you've come across people, intelligent people, who confess to eating food that is bad for them.
Yeah, and I think you've framed it in a way I've never really considered before. It's a really powerful way to think about this is that the narrative in nutrition is even from professionals in this field, it's moderation, treats. You look at food pyramids and sweets and sugar sit up the top. But in contrast to that, you made the great a point of you walk into a petrol station, you have alcohol, nicotine, and junk food. And it's no coincidence that they're all next to each other. They're the same thing, highly addictive, dangerous substances. And I think for a lot of people, including clinicians, it's quite a different way to think of it, because we've all fallen into this trap of thinking of them as they can be part of a balanced diet or an occasional treat. But what you're saying is something quite different to that, which I think is quite novel, and it's incredible that you guys are doing this work. Really, has that work from Jen been published, or is it? I've not seen it.
Yes. Yeah, it's published in frontiers in nutrition. And she initially published her 6-month data, and now we've just published the year-long data showing actual clinical outcomes. It's
Wow.
really another concept is the idea of sugar as a gateway drug. And there are various famous people who have said, well, sugar was the first thing I was addicted to because sugar is psychoactive. It does press the dopamine, the oxytocin. We know it does that. They've done amazing studies in rats. And when we think of our children, we're giving them intermittent reinforcement, aren't we? It's like Pavlovian thing that, oh, you've been good. Here's a sugary treat.
Yeah.
And be careful when you do that, because my wife is a carbohydrate addict, a really bad one. And she will be a carbohydrate addict all her life. And she knows by the age of 16 that was established. And all her life, she's battled with her weight. She's been a huge woman and a small woman and this diet and that diet. And our children surely are so precious. And shouldn't their nutrition be particularly important? We know now that 60% of the diet of young people is junk food. How can that possibly end well? We also know that 38% of the entire world now has fatty liver, including I have children with it. I sometimes wonder why there aren't placards in the streets. And it's because change has occurred. Humans, we're not very good at spotting change over, say, 20 years. And it's only when I reflect, what was the world like when I was young? And there were no fat children. Oh, there was one in my school. I remember his name because there was only one. You will not find a school anywhere now in the UK where there is just one child with a weight problem.
Yeah.
So we are sleepwalking into this, and this is partly what gives Jen and I our energy.
Yeah.
We're trying to show this doesn't have to happen, and we do have some freedoms, and there's as I say, which would you choose? Do you want freedom from chronic ill health, or would you like the freedom to eat whatever you like, but you can't have both? I say to patients, as obviously it's hard for them. It's very hard. Christmas isn't quite the same, although you can do low carb cakes and so on. And I say to them, well, maybe at the moment I'm not giving up on you because I believe you could have better health than you have. When you're very old in a nursing home, you can eat what you like. But for now, surely your life is worth more. What's valuable in our lives? It's our grandchildren. It's our partners. There must be more to life than enjoying junk food. There must be. And if that's the case, let's improve our quality of life. And if you really must kill yourself with junk food in the end, well, why don't you wait till you're in maybe in a nursing home? So that's the kind of thing. I'm often trying to get whole families to do this together. So often I find, so mum and dad will do low carb because one of them's ill. And yet they don't understand that the diet could be most appropriate for their kids as well. Because why wait? Another concept for you is the idea of not chronological age, but metabolic age.
Yeah.
So the wonderful thing about having a big data set is you can interrogate it. So we can ask it questions and we can say, well, how likely is it that we're going to get a normal blood sugar in various situations? So I know that if you have pre-diabetes and you go low carb, 93% of patients at 2 years will have a normal blood sugar. So I can get resolution of that problem in 93% of cases. Let's say they wait and they ignore me until they have type 2 diabetes. Well, I'll try again. At this point, you have a 73% chance of a normal blood sugar if you go low carb. Let's say you still won't listen to me. Well, that's fine. Let's wait 5 years. So if on average you take people who've had type 2 diabetes for 5 years and you convince them to try a low carb approach, I'm going to say 50%. But you can see the percentage is dropping and dropping. The longer we wait, it's not your age that matters. I mean, the oldest person I've got type 2 diabetes remission is 92 years old. So it's not chronological age that matters, but I have a concept of metabolic age. And the more you abuse your body with junk food, you are aging something key in your metabolism. And what it is, I'm not completely sure, but there's certainly telomeres in there. There's certainly liver function. And so it makes sense, if you can, to deal with this early. And we know that Roy Taylor talks about the long silent scream from the liver. It's about 10 years of fatty liver before the insulin resistance and the resulting hyperinsulinemia overcomes your ability for homeostasis. And then you can't regulate blood sugar. But we know there's something there for 10 years before homeostasis collapses. And surely it's a better idea to deal with this early. And I have have an idea, Ben, that this would chime with your clinical practice too.
Yeah, absolutely. I mean, I think, anyone who's in practice would resonate with that idea that once people are far down the road of poor metabolic health, that you are unlikely to get the same sort of outcomes as you would who's come to you earlier. There does seem to be a tipping point in your ability to regain, good health again. And that speaks to that, perfectly. It's a really powerful idea. And I think, like a lot of the work that you've done is in contrast to the way people think about medicine and clinical practice in general. I think we've sort of been trained to go and see people when we're sick, but not to improve health and prevent illness. And this is a powerful message to that, is, you don't want to wait, basically. It could be too late by the time you have symptoms. Yeah.
Also, at a societal level, we should be looking for low-hanging fruit so that, it's much easier for me to deal with pre-diabetes. It doesn't take me long. It's quite easy, and they get results really fast.
Yeah.
And so it's also about bang for your buck and expectations and all sorts of things. But that's where social media can be so helpful, because pre-diabetes is not a really specialist, difficult thing. And it's not complicated by the drugs you're taking, because that later on makes it all a bit more, because once you've been medicalized with a lot of drugs, a low carb approach may need some skill to negotiate, because then if you're on insulin for type 2 diabetes, well, cutting the source of glucose means you're vulnerable to hypoglycemia, because you just cut the insulin. So it requires skill, and it's quite labor intensive. Whereas pre-diabetes, oh gosh, it's just so easy. And we get such consistent and wonderful results. So for me, it's low-hanging fruit. Social media can help with that. And that's why I love Twitter so much.
Yeah, it makes sense. We're going to have to draw to a close soon, but I want to touch on one theme that has permeated your work and interest, and that's the psychology of hope, which I feel like is a really nice way to close out on this as well. So can you speak a bit to what that means for you and how you're using that in practice?
Again, this has been Dr. Jennifer Unwin's life's work, the difference that hope makes to chronic disease. That was the basis of her PhD. And again, I didn't get it initially, but I really do now. Telling people off shuts them down. Who wants to come to their GP to be told off? You don't. And in fact, I have people I used to tell off and then they'd vanish for 3 years and I'd wonder why. Well, it was my fault. With hope is far more powerful. It's nicer for a clinician, but it's much better for the client. So if you can, we've a choice really in a 10-minute appointment. I can wave a shroud at you and say, if you carry on, you'll be dead in 5 years' time. But that doesn't work very well. It's much better to say, if you could trust me, we've got a choice today. I could start lifelong medication, or I think if you could improve your diet, I could have your health so much better in 6 months. Are you interested? And so this idea of hope and choice means what you end up with is activated patients working with you. And that's what I believe in, this idea of collaborative work, trying to aim for in transactional analysis terms, an adult to adult relationship with the people I'm helping. So instead of being adult to child, where I'm telling you off and you feel resentful and cross and sulky, we try for, I'm giving you relevant information, I'm giving you hope, and I'm going to support you. And shall we just try the journey together with the idea of hope? And of course, the other thing that's really helped is the idea I say to patients, what if today you're the heaviest you'll ever be? Why? Perhaps you could take a secret photo of yourself today. And if what I do helps you, you could consider letting me have a before and after photo if you feel proud enough to do that. And you see that has the photos very motivating, because that isn't, maybe you think that photo isn't me. That photo doesn't have to be me. And then I get the wonderful before and afters. I've got some humdingers of proud patients, and the media love those photos. But I think it helps people realize, I'm like George, or I'm like Elaine. She's an ordinary person doing an extraordinary thing. Maybe I could do that too. So hope, very powerful. My final word on hope is think about the placebo effect. So powerful, ubiquitous, we're always trying to eliminate the placebo effect. What if the placebo effect was hope, and we could use that for pain and chronic disease? We could leave it there.
Yeah. Yeah, that's great food for thought. And, I think you're absolutely right. Well, firstly, that, a really beautiful articulation of how you're using hope in practice. I think it really brings it down into the real world for people. And, thank you for that. But, I've often thought the placebo effect has therapeutic potential, and using it in the context of health just makes perfect sense to me. It's a beautiful piece of food for thought to close out our conversation. And it'd be fun to talk to you all day. There's, some really rich takeaways there. And it was also a privilege to hear about the journey of, your journey and the work that you've done with patients and the influence that has had at a, a real macro level locally in the UK, but also globally. And, again, on behalf of listeners, I just want to thank you for the work that you're doing. It's really powerful, and long may it be the air that fuels you to keep doing what you're doing, because we're here in awe and, following in your footsteps. So, thank you again for your time. It's been a real pleasure speaking to you.
Thank you, everybody. Bye-bye.